Today we will discuss about gallstone. First of all, types. Mainly there are three types of gallstone. One is cholesterol, and next is pigment stone, and then mixed stone can be there. Pigment stone is a two type, black and brown. Okay. Now talking about the pathophysiology. In pathophysiology, like how does the stone form? Stone is formed due to there is the certain substance in the bile, certain substance which is present in the bile, right, and which is prone to form as a stone when the concentration of this substance is more, and the concentration of these substances are more than the solubility in the bile, and then they concentrate and from the supersaturated, they concentrate and when they go into the bile, when they go from the liver to the gallbladder, to the gallbladder, and in this gallbladder, the bile which has come and other substances that come from the liver, they supersaturated. The bile becomes saturated. Well, the saturation, this substance also increase in the concentration during their when they increase in concentration, they form the microscopic crystals. First, okay, and these crystals are these crystals, and combined with the mucus of that, from the sludge thing, okay, they from the sludge, and these as the time goes on, they grow and aggregate to form the macroscopic crystal. Macroscopic crystals or stone can be this, and according to the what is the substance over there, according to that substance there can be cholesterol, pigment, or mixed type. Okay, now first of all, talking about the cholesterol stone, in cholesterol stone, in the liver, cholesterol from liver, cholesterol is secreted from the canaliculi and goes to the bile to get excreted. Okay, and this cholesterol is mixed with phospholipid called lecithin. Okay, what is they said that in case of here in the end form, these two combine to form the vesicle, they combine to form vesicles, unilamellated vesicle. Vesicles is formed. Okay, the one-to-one combination is there, and when they reach the this gallbladder, here what happens is the bile salt is here from liver also, bile salt, we can say like this, one molecule of lecithin combined with one molecule of that. Okay, yeah, where what happens is bile salt also combined with lecithin, and what happens is they form the this bile salt combined with unilameral lecithin, they form the microscopic mixed micelle is formed. Okay, and these vesicles combined with one molecule of cholesterol combined with one molecule of lecithin. Here what happens is one molecule combined with three molecules of this lecithin. This lecithin is there, 1, 2, 3 lecithin combines only one cholesterol is lecithin. Okay, so cholesterol require more lecithin when combined as when it forms the mixed micelle, and if the concentration of cholesterol is more, so cholesterol become extra, right? Extra cholesterol is there, then cholesterol combine to form the microscopic crystals, and this forms sludge and microscopic stone is formed. Okay, cholesterol is formed, and this cholesterol stone is formed in this way. Cholesterol stone is formed. Okay, this is the pathology for the generation of cholesterol stone. In case of mixed that pigment stone is two type, right? First of all, the black stone. Black stone is formed by like from the like heme, right? The RBC, we have RBC. From RBC there is heme and globin. From RBC, heme and hemoglobin, mostly hemoglobin. Heme plus globin, right? Globin goes it is a protein, so it is that recycled heme, like heme is degraded to form the bilirubin. Okay, bilirubin, and bilirubin is conjugated and like conjugated in liver to conjugated bilirubin, and conjugated bilirubin is soluble in water. Okay, and there can be few amount of unconjugated bilirubin, like unconjugated bilirubin can be there, like in case of excess hemolysis, spherocytosis and all that. That can unconjugated hemoglobin can be there, and this one is insoluble in water, so it can precipitate, right? It can precipitate and collect as a stone. Like black stone is formed mainly from the unconjugated hemoglobin. Like this unconjugated hemoglobin is like they are similar to like fatty acid, phosphate, carbonate. Okay, these combine with calcium, combine to form calcium bilirubinate. Okay, calcium bilirubinate, another like calcium phosphate, calcium carbonate. Like these all forms the combine to form the like our black. Like this combine to form a stone, and during their process they are oxidized to form a black color. Like during the oxidation process they get a color, black color, so it's called a black stone. So black stones are formed in the condition where there is excess of unconjugated hemoglobin. Where there is an unconjugated hemoglobin is like in case of hemolysis, like hemolysis of the RBC. Okay, in this condition there will be black stone formation. Now finally there is brown stone, like brown stone. Okay, brown stone is formed is mostly formed in CBD. Okay, common bile duct, and in combined bile duct it is formed due to the organisms, like different organisms which break down the conjugated bilirubin, like bilirubin digluconase is there, right? That bilirubin diglucuronidase. Okay, the organism secreting glucuronidase, so there will be the formation of that unconjugated bilirubin will be there, and due to the action of the organism, it is mostly formed in CBD, then in gallbladder, right? And from this unconjugated bilirubin, like in the brown stone is formed. Okay, organism mostly that oxidizes the bilirubin. Okay, that oxidizes the hemolyze the bilirubin, or oxidize the bilirubin and unconjugated bilirubin, and they also oxidize the fatty acids, and this combined from the brown stone. Mostly brown stone are formed due to the organism like schistosomiasis, like in the common bile duct. Now after the pathophysiology we have etiology. Okay, etiology we go one after another. Like first of all there was cholesterol stone, right? Cholesterol stone formed in case of like where there is excess production of cholesterol, like in case of our age, like old age, right? And here obesity. mostly in metabolic syndrome, right? There are more chances for secretion of cholesterol, and in case of pregnancy, okay, because pregnancy or multiparity, okay, and in also case of like in this case, because their secretion of they secrete progesterone mostly, and progesterone has progesterone they do not allow there to be stasis due to the non-dilation or due to dilatation of the it causes dilatation of the gallbladder and prevents its contraction, okay, due to his mostly. And in case of drugs can be there, like something like drug therapy, like estrogen therapy. Estrogen cause more secretion of increased secretion of like cholesterol and other like clofebrate. This is another hypolipidemic drug. They also for like they are the drug which decreases the lipid level of the blood, right, and decrease blood cholesterol for the cholesterol, but they increase the amount of the cholesterol secreted through via cholesterol secreted via our this through the hepatic pathway. Like in other cases, like in cases where there is like gallbladder stasis, like in case of total parenteral nutrition, there is sepsis, there is bone. In this we do not eat food, right? So in this case there is no stimulation, like cholecystokinin is not secreted from the cholecystokinin is not secreted so there is chance of gallbladder stasis. And other cases like some heredity is also said to play some role, okay. Now talking about the pigment stone. Mostly the black stone in case of hemolysis, like hepatosporocytosis. These are causes where there is hemolysis, mainly like sickle cell anemia, hepatosporocytosis, hereditary spherocytosis, and other like thalassemia. In this case there will be black stone and brown stone in case of like fluke like schistosomiasis. Okay, and then in case of mixed stone there will both combined features can be there, okay. Now these are the etiology for this. Now going about the what we do, we have done our pathophysiology, we have done etiology. Now going to the clinical, okay. Talking about the clinical feature, mostly like there is stages. First stage is like lithogenic First of all there will be like our lithogenic state, okay. Lithogenic state which is no stone, but our condition favorable for the formation of stone is there. And next is asymptomatic gallstone is there, where the patient is asymptomatic. And then there is like symptomatic gallstone. There is characterized by biliary colic. Is there. And then comes like our complications. In this NSC there is no any symptoms at all, in asymptomatic gallstone there is also no stones, but there is no symptoms, but there is stone detected occasionally, can be detected during other procedures. For other acute condition, while we do USG or X-ray, we can find that in symptomatic biliary colic. Biliary colic is like it is due to when the gallstone is there and it lodges here, when it lodges there, and due to like the distension, okay, if it lodges here or here, there is distension of the like our gallbladder due to distension, this biliary colic occurs. So it is said that it is a visceral type of visceral distension, right? So there is vague dull pain, right? Vague and dull pain will be there. Mostly they say biliary colic itself can be localized, but along with biliary colic, there can be acute cholecystitis. In case of acute cholecystitis, this acute cholecystitis can be like colicky pain and localized in the epigastrium to or in the right hypochondrium. Then from there it goes like referred pain can be there, like epigastric and right hypochondrium pain, from referred pain to the back and to the tip of the scapula, okay, right scapula, like diphoresis, there is dyspepsia, like fat intolerance can be there, okay, dyspepsia, fat intolerance, dyspepsia, biliary colic, like, and in case of like biliary colic is gone, and in case of complication, like mostly, and most important complication like acute cholecystitis. Acute cholecystitis in most of it is due to the stone, right? And acute cholecystitis has got like features of fever will be there, and then like our pneumonian sign and our Morphy's sign, okay. Morphy's sign will be positive. Morphy's sign is when we press the right into that at the area of gallbladder, we press during our expiration, and while taking a deep inspiration, the patient feel pain, right, in the right hypochondrium, okay, and like pain will be, fever will be there, and that tenderness will be there, and localized pain will be there, localized pain, epigastric and right hypochondrium pain will be there, and then our these are the features of complication, okay. Talking about investigation, of our patient, mostly like CBC can be done, okay, CBC can be done, and in case of CBC can be done, and other like most important is USG you have to do, okay, USG, X-ray, like 10% are radiography. USG can be done, X-ray can be done, and like with the development, like we have got endoscopic here, like endoscopic like ERCP, endoscopic retrograde pancreatic cholangiography, right, pancreatic cholangiography can be done, and if there is stone, impact a stone, and by Dormia basket it can be removed with it in the same setting, okay, and other like after endoscopy ERCP, MRCP can be done, but in MRCP what is there is MRCP we cannot do like other procedure can be done, like Dormia basket can be done, and most during how can we diagnose, like now diagnosis, okay, these are investigation like CBC, leukocytosis will be there, okay, leukocytosis can be there, diagnosis, since like most of the gallstone are detected are asymptomatic, and like they are diagnosed during the other procedure, so they can be left as such, okay, unless there is greater than 2 centimeter stone, or like, or in case of like we have more risk factor like hemolytic anemia, sickle cell anemia is there, hereditary sports, and this cause like metabolic syndrome. In this case we have to think about, but otherwise we can live, right? Live if asymptomatic. And while diagnosis, the most important thing is like Murphy sign will be positive. Like typical biliary colic, you can like biliary colic. I have discussed about biliary colic. Like they occur like after about 1 hour of food or fatty foods, after having fatty food, and they increase in speed up to 10 to 20 minutes, and then they subside, and they may last up to 1 to 5 hours. Like this is the typical characteristic of biliary stone. After 1 hour after fatty food, 10 to 20 minutes for the increase in severity increases for this period, and then may last for 1 to 5 hours, and then after this there can be complete asymptomatic period. But after fatty food or after some period, they can have again another episodes of like pain can be there, okay. And other thing like our all other investigation which I have already mentioned over here, like these investigation can be done. And other thing like while examination, like while diagnosis examination you do, right? These are the in history, from history only biliary colic history would be there in examination. Murphy signs, most all Murphy sign will be there. Palpable gallbladder, if there is palpable gallbladder, it can be due to like it can be palpable gallbladder, like there is one thing called Courvoisier sign, okay. It says like in case of our pancreatic carcinoma, Courvoisier Courvoisier sign is there, okay. It says that in case of pancreatic carcinoma, okay, the carcinoma of this peripancreatic carcinoma, it causes the obstruction of distal common duct, right, and it causes like the non-tender gallbladder, okay. Palpable but non-tender, okay. So palpable gallbladder, while palpating Murphy sign, if you palpate and it's non-tender, in Murphy sign there can be palpable and there is tender. Like if there is palpable non-tender, so it can be carcinoma. You have to think about that. And while sometimes like this palpable but non-tender gallbladder can be due to mucocele, okay. Mucocele, like there is obstruction due to stone, and then these all things from here is absorbed, and then mucus is secreted, so mucocele is formed, okay, and this mucocele can be palpable, okay. And other thing after mucocele, like there can be pyocele, in pyocele like the tenderness, pain will be there, okay. And then these are things help in diagnosis, like after gallstone. Now management in acute stage, like observation. In asymptomatic, I have already told, asymptomatic, just observe, okay. In collision, and in case of we have got symptomatic, you can go for cholecystectomy, okay. And in case of asymptomatic also, I have already told you observation. And in case of like diabetic patient, hemolytic anemia patient who is going for bariatric surgery, and these all things you can go for prophylactic cholecystectomy, okay. And like prophylactic cholecystectomy in case of like risk factor, mostly like hemolytic anemia, like bariatric surgery. Okay, in this case we can go for prophylactic cholecystectomy. And for acute condition, okay, Acute condition, first of all, we'll go for non-operative. Non-operative thing, here we'll go for first nil per oral. Okay, first of all, there will be nil per oral, and then it could be analgesic, and then antibiotic. It covers a gram, mostly gram negative. We have to cover gram negative, okay, and anaerobic. Okay, analgesic, antibiotic, nil per oral. Give fluid also, intravenous fluid, IV fluid you have to give. Okay, give IV fluid, and then after temperature, pulse and other thing, inflammation subside. Then after temperature and pulse subside, pulse is normal, right? Normal, but normal. Then give oral food. Okay, give oral food, and after this you can plan for, after this acute condition over, you can plan for cholecystectomy, and then you can plan for cholecystectomy, or you can do interval cholecystectomy after 4 to 6 weeks. Okay, acute condition, if the symptoms do not subside. Okay, if symptom not subside, do not subside, then then you can, like, increasing symptoms, there is pyemia, like impending perforation, then you can go for emergency. Okay, emergency cholecystectomy, or you can also go for immediate cholecystectomy or cholecystostomy. Okay, thank you.